I'll never forget that day. The staff came and saw me and they said, please, we're not trying to upset you or frighten you, but we don't think you're going to make it. Make sure you give your kids hugs. And when I waved goodbye, I thought to myself, those kids have got no idea. If it wasn't for the actions of Dr. Collette and Nurse Kate, I honestly would not be here.
Nothing prepared me for what I was going to see within the refuges. The mental and physical state of both the women and children truly shocked me. It was hard to believe that this is happening in Australia. It's something you'd expect to see in a third world country where there are no services available.
If we were not available, she would not be here. That is no exaggeration. So she's come a long, long way, and she's actually about to move out of refuge into her own place with her children, and she's safe and her life is totally different.
So domestic family and sexual violence is the largest known contributor to the disease burden for women aged 18 to 44 years in Australia. So that's higher than smoking, it's higher than drug and alcohol use, and it's higher than obesity.
I was on my way out. I wasn't going to survive if I didn't have the help of them. I was told to go straight to the hospital, and I did. Well, I spent 6 weeks in the hospital. I was in ICU for 4 days. So it was, very, very lucky.
So the Domestic Family Primary Care Outreach Team is a planned outreach program that consists of a GP, a nurse, a speech pathologist, and a maternal child health nurse. And they provide holistic medical care to women and children residing in refuge accommodation.
Having them there is something that saves my life. There was no, see you later, no, we can't fit you in today. That is such a big, important thing, especially in a DV situation. You need to have that safety network.
For them to be able to just walk out a few steps to our office, come and sit down, they've got a cup of tea in their hand sometimes, and we just have a conversation. It's non-judgmental, it's trauma-informed. We don't open up any conversations unless the client, it's sort of the client runs the conversation.
Some of my consultations take an hour or more, as we need to let the woman tell her story as she wants to tell it when she's ready. We don't hurry her up into a 15-minute consultation. By taking the service to the refuge, she feels safe and secure. Some of our women, the perpetrators are actually searching for them, and it's really not safe for them to leave the refuges.
I had a client at the end of last year who had experienced horrific DV. Her and her children had been, I won't go into it, but they weren't able to leave refuge due to the safety concerns. Police had no idea where the perpetrator was. We knew he was looking for her. So having doctor and nurse on site and us not having to leave refuge for them to receive medical care, which they did need following their trauma, meant that they could access that service as soon as possible with no risk for their safety at all.
So we're getting a lot of people with very advanced concerning conditions that put them at very high risk of death. There'd also be far more morbidity both with mental health and also other physical conditions, whether they be infections, injuries. We have a woman who had a severe neck injury from strangulation, and also she had a carotid artery dissection. And we have linked her with a vascular surgeon, and we've been able to do thorough assessment on her to ensure that she's at no risk of danger.
A really important component of the program is that it's an integrated model. The PHN commissions a general practice with a GP and a nurse, and then the local health district for a speech pathologist and a maternal child health nurse. And we work hand in hand with the domestic family violence service sector to create a really coordinated service that journeys with the patient and really starts to break down those silos that we know impact somebody's ability to access healthcare.
All the normal GP activities that you would a nurse and GP would carry out within a normal medical practice happens within refuge.
The program was developed because we knew that there was a significant gap in the service sector and these people weren't getting the health services that they needed. So we brought together the domestic family violence sector, the primary care sector and the acute sector to co-design this project or this program to meet the needs of the people who are experiencing DV and residing in refuge accommodation.
With the circumstances that resulted in us being in the shelter. My kids find it very hard to open up or very hard to say anything at all. So having them being able to go out our door and walk up to their office was absolutely imperative to their health.
For children who've experienced DV, we often see like a regression of things like toileting, speech, etc., and behavioural issues. So if we don't intervene early with these kids, those things can exacerbate and they can sort of decline further.
One of the children my colleague worked with, the child and 4-year-old girl, ongoing ear infections, and it turned out if she hadn't have been linked in with healthcare, she would have been deaf within a couple of months. The program was able to get her into an ENT. She had grommets done, and she can hear properly. So, it's massive. We could have had a child lose her hearing, and this program's helped her not.
The first 2,000 days of life, that is from birth to the time they start school, is vital for their development, both physically, mentally, neurodevelopmentally. Early intervention is really important because if there's no intervention and they don't receive help with motor skills, with their speech, with their comprehension, and with their interaction, their social interaction, and also help to improve certain behaviours, then by the time they start school, they're on a downward sloping slide.
This program recognises children in their own right. So we have a really strong emphasis on providing early intervention for children who experience domestic family violence. So that includes speech assessments, developmental assessments, physical health assessments, referral into specialists, advocacy, transport. We provide intervention in childcare centres and in schools. The child's right to live free of violence and live a free, happy, healthy life is really important and central to this pilot.
Well, this pilot has really highlighted a lot of issues. The first one is that we've identified a population who are very disadvantaged and marginalised, and they cannot access services. And so I feel it's very important that we advocate for funding to be able to continue to provide services for them, because if the pilot didn't exist, it would go back to them being disadvantaged and marginalised.
So our hopes and dreams for this pilot is that every refuge in Australia will have access to an integrated and holistic multidisciplinary medical team, so that women and children have access and the ability to heal and recover from their experience of the violence.
I have no doubt that this pilot reduces emergency department presentations, reduces presentations with women in acute crisis with mental health conditions to mental health services and also emergency departments. And I feel that this pilot should be rolled out to all refuges.
When we talk about what the outcomes that this program is achieving and what we're doing, and the program is just going from strength to strength, when we talk about this program to other areas and other regions, the answer is, when can we get this service to our refuge?
Please, I beg you, don't stop. Without this funding and without having the access to see a GP, I would not be sitting here today. It was a matter of my life. Without that, my children wouldn't have a mum.